Medical professionals, what is a shady practice that you witnessed in the medical field that would be a huge problem if it leaked? So, worked for a private ambulance service that would still run high-priority calls out of hospitals if sending the hospital couldn't provide a service, either due to no personnel or equipment, or nursing homes/care facilities that didn't want to overuse 911. Well, dispatch would lie all the time about our ETAs to facilities. Say one of our units was 40 minutes away, hospital would call us up, dispatch would say 20 minutes, that way the hospital wouldn't call another service that might be closer, and by the time the sending hospital realized we weren't there in the time quoted, it would be too late/silly to call another service. So, in other words, critical care was often delayed to make a set number of calls since calls equal money. Next story, emergency medicine physician. Punitive use of needles, i.e. sticking someone with a needle when they didn't need it at all or selecting a gauge that will cause significantly more pain in insertion. Therapeutic waits by triage staff ensuring that a patient who is behaving negatively is made to wait longer than their triage category would suggest on its own. Abuse of mental health detention powers to control psychiatric patients rather than attempting to verbally de-escalate or offer voluntary administered sedatives. And intentionally escalating arguments with patients to goad them into abusive or violent behavior that will allow security to forcibly remove them from the department. Next story. Refusal to do things differently because of prior training or bad advice. Tons of doctors I would see, I used to be a medical rep, would be using super outdated methods or tech or refuse to acknowledge the usefulness of new things, simply because they went to med school and learned it in a certain way. And that's not just me as a sales guy talking. There were doctors who legitimately wouldn't do tests for things, even if it was no extra cost to them or the patient, just because it came along after they got in their set ways. Next story. Work for a medical professional. We are seeing a shady practice really coming to light on social media and people are eating it up. At-home, DIY orthodontics. That's right. People are literally treating themselves with invisible aligners, like Invisalign, only you take your own molds, mail them in, and voila, treatment. Here's the problem though. Yes, it's a cheaper alternative, and yes, it is heavily marketed on social media and online in general. However, when you go to see a doctor or a specialist like an orthodontist, you're paying for what they know, years of experience and school you didn't have to go through. People are losing teeth, ending treatment with open bites, ending with spacing or crowding in spots that didn't have it before, all because you wanted to save some money and do it at home. And yes, these problems do create periodontal issues if they are not treated. The issue is, the companies doing these aligners claim that you have a dentist, not even a specialist, overseeing your care. Except you don't. You aren't allowed to go to the dentist listed on your box because guess what? You aren't their patient. And when you call up asking for a tax ID number so you can file for insurance, no, you're not going to get that either. Why? Because then they'd have to claim responsibility for you as a patient and put themselves in a position to potentially be sued by someone they haven't even seen in person. So, why are they signing off on cases so people can receive these aligners via mail? Well, they get paid by these companies to do so. People just don't get it. We have patients who have tried this come in here and wonder why their bite is worse than where it started, or why they have major overjet now. Well, it was just meant to fix one tooth. It never fixes one tooth, folks. Your whole mouth is involved when teeth start moving, which is why x-rays are important. So if there's a short root, we know before putting you in treatment because the possibility of losing it during treatment is there. Or if there's other issues that need to be addressed, we can fix that before putting you in Invisalign or braces. Orthodontics should be treated like any other medical or dental procedure. If you wouldn't give yourself a root canal or perform surgery on yourself, don't move your teeth on your own. See a professional. And if you decide to take the DIY route, make sure to put some money aside for the ortho you'll be seeing afterwards to fix the open bite that you didn't have to begin with. Next story. All right, everybody, I'm going to blame TikTok. Can I blame TikTok for this one? I don't know where this trend's coming from. TikTok and Instagram ads. Those Instagram ads know everything about you. All they do is serve me clothes and stupid fashion, and I click on them every time and it works, okay? So thank goodness I don't have teeth problems. I have a lovely smile, because if I did, I would fall for this. Anyway, next story. So, I don't have anything too bad, but I was working visitation at a nursing home where they didn't have a policy to count medication. If you know anything about nursing homes, is that you either have really trustful nurses or nurses that just get rotated a lot, mostly for stealing medication. Next story. A lot of ERs are really super understaffed. I've seen multiple instances of one doctor responsible for 20 plus patients at a time, or one nurse responsible for 5 to 10 patients at a time, with one or more of them being ICU admits waiting for a bed. The nurse-to-patient ratio in an ER should be 1 to 3 or 1 to 4. Next story. I work in a hospital. I'm aware of a case where someone's medical information was accidentally copied, then pasted into the wrong patient's file. This resulted in the wrong patient getting their neck cut open for a surgery that they did not need. The correct patient actually had thyroid cancer and got their treatment delayed. Lawsuits followed. Next story. I crap you not. I used to work as an EMT, and I responded to a call for a patient who was experiencing serious respiratory issues. We got on scene and found out that our patient was an elderly man who had recently been taken off of hospice care because his expected mortality became less apparent, so he was placed back in nursing home care. Because of his fragile state, however, one of his family members, I forget which one, signed a DNR/DNI form on his behalf. That's a do not resuscitate, do not intubate, which essentially means don't perform basic emergency medical interventions on this patient, even if he goes south and is about to die. There are a lot of other things a person can check off on the form, like do not transport to hospital, etc. But anyway, when we found this out, we had to tell the nurse that legally we couldn't treat this man, nor transport him because his DNR did have the do not transport box filled in. She didn't like that one bit, so she asked for it back so she could destroy it. Huge no-no. We made a copy, took it with us, and told her that we're not taking this guy at all. 30 minutes later, we hear of another crew that transported the guy because there was no documentation contradicting the process. We ended up faxing a copy of the DNR to our shift command, and I'm pretty sure the nurse was fired after that. Next story. Time limits on labor. They're BS in most cases. Failure to progress is generally failure to allow labor to start on its own, and introducing it before is actually time to do so, and/or augmenting with the expectation that a woman will deliver within X amount of hours. Cesareans are highly overutilized. Also, I encourage anyone interested to research nuchal cords. They are often used as a scapegoat for decels in an infant heart rate, failure to progress, stillbirth, etc. Yet many modern research shows that this is not the case. Next story. My county hospital, which is a teaching hospital, engages in a practice called overslapping surgery. A lot of hospitals do this, but patients don't know about it. They do 2 surgeries at the same time because the attending parts of the surgery is very short. So the surgery residents/fellows do all of the other stuff under his direction, but he won't necessarily be supervising or even in the room. That way, the senior surgeon can bill for 4 procedures while only really doing 1 or 2. It happens in a lot of hospitals, but you're never told about it, and that's my issue with it. The patients aren't told about it, at least at my hospital they aren't. If you were told that your surgeon will be performing another 2 surgeries at the same time as you, would you still sign off on it? I probably wouldn't. Next story. First and foremost, the ridiculous cost of literally everything in the medical field. A lot of precise equipment is justifiable, i.e. artificial heart valves made by hand in sterile clean rooms, cardiac stents, etc., but a screw for $10,000 is insane. Computer processors are manufactured from beginning to end in clean rooms as well, and probably under more exacting spaces. Medical equipment can be manufactured and then cleaned and sterilized with gas, UV, radiation. Most everything is manufactured for single use for infection prevention and fear of cross-contamination, so the volume of waste is just obscene. Plus, much of the garbage is classified as biological waste, so getting things recycled is difficult. Then there are personnel shortages because hospital staff are sick of dealing with people. I was in critical care and almost quit nursing because most nights I was a glorified waiter that was poorly treated. We are held to customer satisfaction scores no matter what, whether your complaint is valid or if you're a heroin addict on your 10th admission for the month and we didn't push the Dilaudid fast enough for you to get that high feeling. And then finally, there's narcotics in general. Next story. Last year anesthesia resident here. Seen a lot of shady crap, but this one was the worst. On my first year of residency, I was on call during the night with my boss, an anesthetist, who had a really bad rep, and I didn't know why or the details of it. But after starting a surgery at 2 a.m., he just left, and I didn't hear from him for the rest of the case, and woke up the patient. After that, I counted the sufentanil, and we used narcotics 1000x as potent as morphine, and we were missing a lot, we're way off balance. I searched for my boss everywhere to tell him, only to find him intoxicated as hell on a chair near the on-call bedrooms. I now knew where he got his bad rep from, and he went in rehab a few months later. It's pretty scary because we represent less than 1% of doctors, but represent 15% of doctors with addiction or abuse. In Canada, at least, the incredibly easy access to narcotics, ketamine, etc. is probably the #1 factor. Next story. I've seen it plenty of times in general government hospitals that generally treats poor people here in Mexico that I used to work at. Usually, since it's a government hospital, it gets overcrowded with hospitalized patients. There have been times where it's so crowded we would need to use the floor to lay people down. And usually, we used to get a John Doe or Jane Doe every once in a while, mostly people who got run over while on drugs, and they would be intubated and unconscious for weeks and even months at a time. When we get a patient that is considered more valuable, however, that being someone with a known name, age, date of birth, and family members that needs a bed but all of them are occupied, one of the head physicians will just say, "Well, just disconnect John Doe." And they'll do it, even though euthanasia is not legal in Mexico. Then the nurses or the interns would go right up, disconnect John or Jane Doe, extubate him or her, and write down cardiac failure as a cause of death. Their justification was always something along the lines of, "Well, it's just another homeless junkie that got hit while being high. They had it coming. No one's gonna miss them." Never in my life have I seen such disrespect for human life, even if it's someone who is frowned upon as a burden to society. I'm glad I don't work in that hospital anymore. Next story. There was a big scandal at Mass General, consistently one of the highest rated hospitals in the US, and this happened a while back about simultaneous surgeries. Let's say you needed a surgical procedure that should require being under anesthesia for an hour. The hospital might instead put you under for 2 to 3 hours, while the surgeon operating on you rotated back and forth between you and several other patients also undergoing surgery. General anesthesia always came with a certain amount of inherent risk, and that risk is amplified the longer the person is kept unconscious. Even worse, the hospital was not informing the patients that they would be sharing a surgeon, and therefore staying under much longer than medically necessary. The hospital claimed that this was the best way to make the use of their highly trained surgeons, and there is some truth to that, but it feels really sketchy to not tell the patients about it. They could have easily given people an option, take a 4-hour surgery with our best surgeon, or a 2-hour surgery with a very competent but more junior surgeon, and informed them of the risks involved in taking the longer procedure. Next story. Copying and pasting notes in the medical record. For example, Dr. Dingbat does rounds in the ICU on Monday, makes a note on a patient with vitals and a general assessment and plan. Then Dr. Dingbat does rounds on a Tuesday and copies his Monday note, pastes it as the new Tuesday note. Dr. Dingbat does rounds on Wednesday, same thing, Thursday, same thing, etc. Edit. Also, if Dr. Dingbat has residents, interns, or fellows around, they are all copying and pasting the same note too. Next story. I've spent most of my career as a software engineer, writing medical software. Every company I've worked at has had an insanely tight QA process around every bit of their software. Like a test might fail that really only means some of the data might look weird on the screen, but that still holds up deployments until we either fix it or modify the test to fit current requirements. We do everything we can to sanitize and standardize our data. We have people who spend a significant portion of their job just looking out for new security vulnerabilities and whether we're affected by them. Seriously insecure code from a senior manager, obviously stuff like SQL injections and XSS and stuff, will get them put into a performance improvement plan where they have like 2 months where every bit of their code gets scrutinized, more so than usual if it all gets reviewed. And if they keep writing it poorly, they'll be fired. The company pays for classes too. You aren't just on your own figuring out how to improve to keep your job, but the security and correctness of our software is an insane concern for us. I've interviewed engineers with tons of medical software positions on their resumes who couldn't tell me what SQL injection is. I've worked integrating hospital feeds with our systems where the engineer had no idea why he should bother to standardize his data. I've seen other apps that ours had to work with that were hosted on outdated and insecure web servers, and such because the engineers at that company were all too busy rolling out new features. I've seen new features get rolled out for EMR software that our software has to talk to that basically brings down an entire clinic's system for the day. Yeah, tons of medical software is written by companies run by doctors. Many of these apps started with an initial code base actually written by said doctor. There is a real important lesson why software engineering is a separate degree from a medical degree. But a ton of doctors fall into that category of person who is really really smart in a couple of areas, so they think they know everything and don't really listen to people who disagree with them. Not every really smart doctor is like this. Some understand the limits of their knowledge and trust the people they hire to know more than they do. But you have a ton of software in the medical field where it was written by a smart person who didn't really know how to write software. It's kind of scary. Next story. As a pharmacist, there are a few pain clinics that send in prescriptions for heavy-duty pain medications. For high doses or long-term use, we have to use a diagnosis code to fill. Well, there are a few that refuse to give that information to the pharmacy as well as the patient. With the opioid crisis in full swing, there are these clinics who push drugs without a verifiable reason. If they don't give the codes to a patient or pharmacy, they can't get in trouble for malpractice as it applies to inappropriate drug dispensing. Luckily, for my state, that will soon change the legal requirements that would require proper diagnosis for dangerous levels of opioids. Next story. Forcing staff to continue working with serious contagious illnesses like TB. I worked on one hospital like this. We were short-staffed and they really didn't seem to give a crap who was on a TB outbreak and would make us come to work anyways, while doing mass amounts of overtime. I ended up quitting because I actually felt like I was going to die. Meanwhile, though, every patient that came into the ER got to get exposed to all of us with active TB. We are supposed to be helping the ill and injured, not infecting them with tuberculosis. Needless to say, this hospital has been sued countless times for crap like this. Next story. I'm not a medical professional, but my buddy is an EMT and took a 3-year-old with flu-like symptoms to a local clinic. The doctor there quickly diagnosed him with a minor cold, but my buddy disagreed and said it seemed like he was getting pneumonia. The doctor chewed his ass out in front of everyone and humiliated him. The kid's parents' kids took him home, and he ended up going into cardiac arrest and dying. Next story. Sort of off topic, but I've tattooed multiple nurses that have stuck their fingers right into their bloody tattoo when I finished. For those who don't know, that's called cross-contamination because then they'll put that bloody finger on a doorknob or their credit card or whatever and get hepatitis all over everything. It's a big deal, and we're all trained not to cross-contaminate. So as nurses, they should know the drill way better than me, but nope, touched the damn whole bloody tattoo and had to get a very condescending cleanup by me. Now, I watch nurses very carefully when I'm getting anything done at a hospital. Next story. A certain 3-letter pharmacy chain pushes pharmacists to fill 400+ scripts a shift. So, on average, that is at best 80 seconds to confirm that the little white pill is the correct little white pill. The dose is correct, the directions are correct, and the PT name is correct. All while 30 people are in line, 3 phones are ringing, 5 cars are in the drive-thru window, and you are understaffed as usual. It scares me how many errors are made and never caught by the pharmacy, and never noticed by the patients. Alright guys, so let me tell you, I used to work at Walgreens, and while I am no longer employed there, my allegiance remains. If I walk into a 3-letter pharmacy, yes, I will catch on fire. And did I work in the pharmacy? No, but the people in the pharmacy were cool, and I had a crush on one of the ladies, and it never went anywhere. But you know what? I hope everyone in that pharmacy is doing well and not being rushed to do 400 scripts an hour. Good grief. Anyway, next story. So, a pretty horrifying accident happened in an OR in a hospital that my school was rotating in. The patient was having open heart surgery, and the CRNA used up all of their stock of anesthesia. This was a larger patient who metabolized the drugs quickly, and the patient woke up in the middle of the surgery. Their chest was split wide open, and they suddenly started making the most awful grunting, groaning sound. All of the medical staff had to hurl themselves on top of the patient as their arms and legs started to writhe. The surgeon started screaming at the CRNA, who started to scream for more drugs as the staff tried to immobilize the patient and keep them from disturbing their open chest. Someone then rushed in and the staff pumped the patient full of drugs to knock them back out and induce amnesia. What bothers me about the whole event is that the patient will never, ever know that this happened. The records of what went on in the OR will be sealed away. That doesn't sound so bad, right? But there are people who have had things like this happen to them and they remember it on a subconscious level. They can start to have nightmares and other psychological issues and won't know that there is a reason they are feeling this way. The only way to get the records of that surgery would be to get a lawyer and make the hospital hand them over. And who would do that without anything more than to go on a feeling that something bad happened to them? Next story. Your doctors aren't necessarily telling you the truth. I'm a post-op surgical nurse, and a few times I've been told in report that the doctor accidentally nicked something they weren't supposed to, and while they fixed it up right away, we should be watching for complications in case it came unfixed. The patients weren't told this. Also, not shady, but I think people would be surprised to realize how much influences nurses have on their care. Next story. Worked in a hospital as a tech on night shift. Had a patient who had a trach and was on a vent. He was with us for a while and pretty cool for the most part. One night, he just got super combative and pulled his vent off and wouldn't let us put it on, so we had to hold him down to do it. When we got it back on, he kept pulling it off, so they decided to restrain him. Poor guy was restrained all night, and there was absolutely no documentation by the higher-ups that he was restrained, because we had to document he was doing it every 15 minutes or so, and I was specifically told not to mention what happened to anyone. So that's the only really shady thing that happened. I left not long after that. Also, I told the tech on the day shift that we had to restrain the guy for a bit when he pulled the vent off despite not being told to. I'm not sure what day shift did with that information, but I feel bad for that dude. He was cool. So, I guess medical professionals not documenting that something happened is shady, especially when you had to restrain a person with restraints. That's shady AF. Next story. Not healthcare professional, fake insurance. You buy health insurance and go to the doctor recommended by health insurance. His wait time to see patients is 4 to 6 weeks. The cash price for the visit is $65, but through insurance is $50. Insurance costs you $500 a month. Well, due to the doctor's availability within network, you can see him once a month, so each visit is $550 to see the doc, before ordering anything extra. So now the doctor wants an MRI, except the MRI available within network either isn't sized correctly or is unavailable. The MRI is $1,000.05 or something copay for out-of-network, even though the cash price for the facility is $600 if you qualified for uninsured status. You're penalized for having insurance. You're also told it's the same exact MRI machine, so the out-of-network premium was just a cherry on top. You then return to the doctor now, probably 2 months later. You've now paid $1,500 for insurance and $1,100 out of pocket for a consultation, MRI, and review the MRI. The cash price for the same services was $730. You don't need to pay for it if you're unemployed. Because of the results of the MRI, you need a specialist. Except the only ones within network have an 8 to 10 week waiting time. So now you're $2,500 paid to nothing but insurance, and you haven't seen a doctor who knows anything yet. The specialist is available every 2 months now, but he requires testing on random crap that has zero relation to your complaints. But hell, he's a specialist and you're not, right? It takes you 2 visits at $150 plus whatever tests and scans they need done per test, 1 visit to order the test, the second to review it and order another. If he ordered 4 tests, you spent over 1 year and 13 months, $6,500 to have an issue identified. You're paying all of your normal bills on top of that. He recommends you to another specialist now that it's identified, but that specialist also has a 2-month waiting time, and he will need to rerun some of those tests for accuracy or whatever justification. So in turn for this fraudulent care, the insurance routes more patients to the same doctor, increasing wait time and making thousands while you're simply waiting to see the doctor. Once you do see him, you'll repeat this cycle of pointless tests and specialists who need to repeat tests. The doctors and insurance work together to pull as much money as they can while never really treating the issue. 2 years later, you see out-of-network doctor out of frustration. You pay cash price for which is cheaper than out-of-network, by the way, and he solves your issue in 14 days, 2 visits, while explaining this scam to you. And you slowly realize you gave tens of thousands to scam artists who didn't care how effed up your spinal cord was and just wanted money from a person who's bedridden and unemployed. You say wow and file complaints with insurance. Your complaints are noted, no refunds, and they don't care. You contact the hospital, and they say contact insurance. You contact a lawyer for a bad faith suit. They inform you that it'll take a year or 2, and the money won won't cover the lawsuit. You didn't pay them enough to warrant a lawyer to get it back, essentially. Meanwhile, the only thing you have left after 2 years of bedridden unemployment, did I mention painful agony, is a large backpack of clothes at your parents' house in another state, while your insurance just walked away with the cash equivalent of your life and forever destroyed your credit score. So now your taxes pay for everything I need and most of my debt for the foreseeable future, so health insurance and hospitals can make more money. TLDR is, health insurance will work together with specific offices to bill you as much as they can, as long as they can without helping you. Don't get insurance if the injury causes you unemployment. Just settle the debt after. Presbyterian Health Insurance and New Mexico Orthopedics. Next story. I used to work for one of the biggest healthcare systems in the US. The endoscopes are nasty and broken as hell. We know it too because I was sent to solve the problem. Lack of training and discipline of the workers who are supposed to sanitize sanitize them was a huge issue. These things can cost one of their salaries, and they were not handling them with care. Some doctors go through like 4 to 5 endoscopes until he or she finds a decent one to use. Next story. Unqualified staff. I work on a behavioral health unit, and I really see it with nurses because there's such thing as a nursing shortage. I think some for-profit nursing schools are really pushing people through with only the info they need to pass licensed exams, but with little practical knowledge. While a good nurse can be your best friend, a bad one can literally kill you. We had nurses who gave insulin without checking blood sugar, one who gave a huge injection into a muscle, which can cause an embolism. I've heard nurses, I was a tech at the time, who would ignore critical blood pressures. There was even a travel nurse once who would go into the break room and sleep during most of his shift, meaning that the tech was left alone on the floor to deal with emergencies. I've also seen nurses goad mentally ill patients into fighting and arguing with them so that they can give them sedating medication. It's also almost impossible to get rid of bad nurses because hospitals only care about meeting staff ratios because it looks better. Next story. In Florida, it is starting to surface right now, but being in the mental health and substance abuse fields, I do patients' intakes and hear stories all the time about mostly halfway houses that basically want you to relapse so they can keep billing your insurance. Other ones that pair up with other treatment facilities and get paid to house patients on the side so they can get around different regulations and it be cheaper for them. A long list of effed up people taking advantage of those who have nowhere else to go during the lowest point in their life and are finally able to seek help. Next story. My husband used to work at an urgent care that hired medical assistants instead of nurses. He once caught one priming an IV line with the open end sitting inside of a sink. He corrected her and told her to throw it out and start again. She was defensive and offended because apparently that was how she had been taught to do it by the other medical assistants. Next story. I worked on a maternity floor for a bit. When babies are born, addicted to drugs, they are scored based on series of symptoms. This score determines if and when the baby can return to the family. The mother was taking Suboxone to combat her addiction and was genuinely trying. One of the criteria to score is if the baby sneezes multiple times in a short span. The infant sneezed once the whole time the other nurse and I were scoring it. Well, she blatantly told me she was going to give him a point for one sneeze just so the family wouldn't get custody. As a student nurse, there wasn't much I could do or say, but I was appalled. And spoiler, the family got custody and are doing great. All right, so it's not all nurses, but why are some nurses just psychopaths and abusive and power? I'm starting to realize now. Yeah, actually, if you think about it, it's the perfect profession for people who are insane and evil. They can just control their will and say, oops, he died anyway, next story. So, worked for a summer as a scrub in an operating room during nursing school. I worked on primarily gynecology surgery. Some surgeons are super lax about mixing instruments between the vagina, the least sterile part of the body, and work they're doing up in the abdomen. Their rationale is, well, we cleaned it before we started, which is really honestly not enough. And we're supposed to be using 2 completely separate setups for the abdomen and for the lady bits. Next story. Happening right now in New Zealand is the revelation that surgeons are using non-surgical grade instruments in their surgeries. This means that surgeons are using vice grips from the automotive store, pliers, spanners from the DIY store, and whatever else. This leaves rust particles and other crap inside patients. Next story. RN of 7 years experience here. This isn't a shady practice, but it's terrifying in its own way. The nurse taking care of you or your family member is very likely an inexperienced nurse. When I say inexperienced, I mean a year or less out of nursing school. That isn't so bad in and of itself, as we all start somewhere, but the problem is that chances are the majority of the nurses working the floor are just as inexperienced. There have been days I've worked and it's been me and 5 new grads. There have been days where the unit doesn't have a single experienced RN on board. That's a problem. I'm not hating on new nurses, but the healthcare environment is so toxic that experienced nurses are moving on. They become educators, managers, administrators, nurse practitioners, whatever. Very few stay on as career nurses. We need experienced nurses on our floors. Without them, when a new grad has a question, they have no one to fall back on, no one to guide them, no one to let them know your patient is about to effing code, dude. In turn, that leads to stressed out new grads who get frustrated with floor nursing, so they move on to other things, which compounds the above problem. Next story. I'm surprised no enterprising lawyer has popped into this bubble yet. Blatant duty hour violations by residents. ACGME has opened themselves up to huge liability by creating a system that often punishes residents for duty hour violations. It's an entirely self-reporting system. Residents go on a website and enter the hours they worked, and I would say most just try to ballpark it. However, a large percentage are committing serious violations of duty hours. However, if they were to start accurately reporting duty hours, that leads to having to enter explanations for why hours were violated, and eventually your program being placed on probation or even losing accreditation. So you could actually lose your job for reporting your duty hours correctly. It would be very simple to open it up, start with a malpractice case, look at every resident that was involved in treatment, subpoena their duty hour logs, and then subpoena their ID badge, swipes like parking and doors, etc., show a systematic pattern of violations, and go after the people who have set up the system and perpetuate it, the individual programs, and ACGME. Next story. We're supposed to take 2 separate blood samples at 2 different times by 2 different people for group Unsafe, so that if one person messes up and takes blood from the wrong patient, then the second will catch the mistake and prevent patient being given blood of the wrong type. So everyone totally just takes 2 bottles at once and then just writes 2 different times. I raised it one time to watch the person squirm. She gave me some line about, "Oh, yeah, I just take like 2, so if one doesn't get tested properly, they have a spare. I'll take another one later." Normally, people justify it by saying they don't want to bleed the patient twice, but she was so full of crap. Next story. I, as an oral surgeon, once hired an employee to my office who had a phobia of using the same toothbrush twice. I'm unsure of the specific name of the phobia, which I discovered one day, though, when I saw her replacing used, bleached toothbrushes in their wrappers and putting them back in the box to give to kids. When I confronted her, she became irate and directed me to a website where people with this phobia congregate. Apparently, it is something of a phenomenon. Next story. Hospitalist US doctor here. I've seen families talked into hospice for the patient when a second opinion might have saved them. Also, when medical errors occurred, the explanation in the chart reversed or muddied causation. If unnecessary IV fluids eventually fluid overloaded a weak-hearted patient into a weak attack and sudden lung flooding, what was documented was a sudden unprovoked heart attack from the stress of illness caused the fluid to back up into the lungs. Although that might legit be a doctor convincing themselves that was the way the things happened. But medical errors seen by doctors and anyone else in hospital settings seen by Johns Hopkins research estimates to be the number 3 cause of death in the US. Might be higher if we knew the numbers in other healthcare settings. The only type of medical error that's been reduced in the last, decade has been hospital-acquired infections. The rest of the errors get swept under the rug. And then, like cops, we feel weird reporting colleagues, so nothing changes. Next story. Not directly treatment-related, but one thing I often see with non-English speaking patients is the use of bilingual staff to interpret. Just because someone is bilingual doesn't qualify them to interpret in medical settings. The common excuse I hear is that it takes too long to get someone, or the provider themselves are bilingual so they don't need an interpreter, but they can't be further from the truth. I've seen this the most for Spanish, since that's the dominant non-English language in the States. Nurses or doctors will pull in the cleaning staff to provide post-discharge instructions because they don't want to pick up the phone and call an interpreter, so they muddle through it with someone who barely speaks any English themselves. In one case, I heard a bilingual scribe who got pulled in to tell the patient to take their meds 3 times a day instead of once a day, which could have killed the patient. In another incident, I heard of the patient being misdiagnosed because the friend interpreting for them gave the wrong description of the symptoms. So stop thinking your 2 years of Spanish in high school or Spanish is good enough to talk to patients about complex care. You're doing them a disservice, putting their lives at risk, and potentially costing your hospital/practice millions in readmittance penalties and unnecessary hospitalizations and treatment. Next story. Oh man, I could go on. Nurses silencing patients' call lights. Nurses refusing to check quickly on a patient that is bleeding out because they're busy on the computer. I know important work is done on the computer, but when it comes between paperwork and saving the life of a man who is literally bleeding out in his bed and his blood is dripping on the floor making a puddle, I would say the life is more important. Oh, and then next, there's the infection control. From gowned-up nurses/PCAS leaving patient rooms and going into clean supply rooms to said people going into dirty utility rooms to grab equipment for a patient room. There's medicine laying around everywhere, countertops and supply rooms on top of portable workstations and public hallways, medicine for everyone. There's nurses refusing to call a code because they don't agree with the code the doctor is calling. I understand doctors can never be 100% right, but my understanding is when they call a code blue medical emergency adult, they may mean some business. Then there's hospital staff not giving bedridden patients baths, like ICU people that are in comas, or even the awake people that just can't leave their bed for XYZ reasoning, but still signing off that they did give them baths. Then there's surgery rooms. I've seen a physician literally walk into an operating room he was supposed to be in while the patient is prep, out, and on the table, and the doctor had a freaking cup of coffee walking into the surgery room. Then so many times seeing doctors stroll through sterile areas, A, not wearing their correct sterile protective equipment, B, shoving their hands down their pants to pick out whatever wedges they have, and proceeding into the surgery room without sterilizing, and C, just wandering in and out of the room without following proper sterilization procedures, like to take a phone call in the middle of surgery because why not? Then there's doctors not sanitizing their hands after each patient bedside round. Mind you, we have hand sanitizing mounts every single patient room. Then, I've seen everything from opened products being dropped on the floor, then picked up and proceeded to be used on a patient, to like linen items or pillows and such, dropped on the floor in a public hallway and then given to the patient. I've seen leg compression machines literally passed between two patients regularly because there weren't enough machines to go around. Nurses/PCAS will make up vitals because they don't feel like checking up on the patient and then having to tend to their needs, questions, getting something, etc. Then, when patients leave the room, some supplies that they haven't used will go back into supply rooms. I'm not sure if this one is debatable, but we have. I can't think of the proper term right now. Isolation rooms? But yeah, those products go right back into the clean supply. Then there's staff leaving patient charts around, staff mixing up patients, and even worse, their meds. And then finally, the best part. Everything, literally everything gets at least triple charged. Surgery, every little bit of equipment, from actual screws and bolts and stitches that went inside of you to the cotton balls used to wipe your blood or the paper procedure coverings. In recovery, they charge for alcohol prep pads, toothbrushes, every little thing, and I know the prices of everything, so I'm pretty good at guesstimating how much a run will cost the hospital. For example, automatic visit to the ER before admission into a room is $500 overnight stay, $1,000 per night. Depending on the surgery, anesthesia is $1,000. Minor surgeries can run anywhere from $10,000 to $30,000. In the vascular section of surgery, I've seen caths bought at $80,000 hospital price, triple that price for the patient, and that's just for the one cath. It's not even counting the surgery or the stay yet. Anytime you get coded, add $3,000 to $5,000. They even charge you for the body bag. Next story. Doctors in the work/comp auto insurance network are completely in the insurance company's pocket. The less they find wrong with you, the less money insurance companies have to pay. I've personally known doctors who write an endless supply of oxidone to a people who really need surgery/physical therapy just to save work comp money. It's disgusting, and one of the reasons why there is an opioid epidemic in the US. Everyone in the legal field knows about it, but not one single doctor has ever been prosecuted for it as far as I'm aware.